You're on scene with an apneic patient, and you're watching the EMT student bag the patient. The bag reinflates, chest rises, everything looks good, so they squeeze again. But what if I told you that in those few seconds between breaths, you might be setting up a cascade of injury that could follow the patient long after you've cleared the call? What if the very technique we've been taught as basic airway management is actually one of the most physiologically complex interventions we perform? Two things may happen when I tell you that. First, hopefully you realize the importance of this skill and that whoever is performing it should be both skilled and knowledgeable in it. Second, you might become scared of the unknown, scared of the complexity. But just because something is complex doesn't mean it needs to be scary or hard. Our guest today, Melody Bishop, spends her time helping make these concepts understandable and less scary. In fact, she's written a book on mechanical ventilation, and the link to that is in the show notes. She's going to help us break down the various factors in this very important skill that you need to start thinking about on your next call.
You on 8? You on 8? Okay, you're clear. Stand by for your base.
Welcome to Loud and Clear, the podcast that cuts through the noise in paramedic education to bring you the insights that matter most in the field. I'm Ross Orpet. My co-host Will Berry sat down with Melody Bishop after her talk at FASTCAN. They dive deep into often overlooked concepts in mechanical ventilation. Melody Bishop, a registered respiratory therapist and certified clinical anesthesia assistant who has spent over 13 years in critical care medicine. Melody has worked everywhere from remote flight medicine operations in southern Canada to operating rooms and intensive care units. She has made it her mission to take the scary out of mechanical ventilation. She's taught everyone from nurses to paramedics, and she's here because she believes we need to fundamentally rethink how we approach something as seemingly simple as squeezing a bag. In the next few minutes, we're going to challenge what you think you know about bag mask ventilation. We'll talk about why insufficient exhalation time might be doing more damage than too much volume, what driving pressure really means and how it applies to your patient, and how the physics of laminar flow could change the way you approach your next airway. Whether you're running 911 calls with 5-minute transport times or working in a system where mechanical ventilation is becoming the norm, this conversation will change how you bag your patients.
Loud and clear, number 2, go ahead.
All right, I'm Will with Loud and Clear, and I'm here with Melody Bishop, who just presented at FASTCAN. Thank you so much. Your talk was all about BVM and a little bit about mechanical ventilation, but I wanted to jump right into a couple things you said that stuck out to me. Well, first off, what do you think is the biggest mistake folks make when all they have is a BVM?
I truly believe the biggest mistake is insufficient exhalation time. I really, really do. I feel like we train ourselves to see that bag reinflate and think that our lungs are doing the exact same thing. They're deflating, and I can go ahead and give another breath because the bag's full. But I don't know, even more than that, I feel like sometimes when we're teaching bag mask ventilation, we have this idea that anyone can do it.
Hmm.
That like, oh, give it to it's just
Hand it off to the lowest skill level, yeah.
exactly. It's just like, oh, you could have a member of the public do it if you needed to because of hands or but at the end of the day, it is something that truly can cause so much injury to our patients. And sometimes that oversimplification doesn't do justice to really what we should be doing to give best care to our patients. So I think probably that would be the biggest mistake, but actual technique would be insufficient exhalation time.
Yeah, you touched on a couple things. We hear a lot about delivering too much volume and too much pressure. So squeezing too hard and too forcefully. But you also covered a couple other things. For example, driving pressure.
Yeah.
Talk to me a little more about that.
Yeah. So a lot of people think that the pressure we're applying is, immediately pushed into the lungs and magically a breath appears. But at the end of the day, like balloons don't just pop because they're overinflated or too much volume. When it comes to mechanical ventilation and lungs and injury, what we now know with the body of research is that our alveoli, it's not just about overfilling them or overpressurizing them. It's actually about that change in pressure that the lung is experiencing. It's actually about the amount of push that the lungs feel. So even if they don't end up with too much pressure or end up with too much volume, if that rate of expansion, to simplify it, is too high, it can cause a massive inflammatory cascade and injure the lungs. And it is this concept of driving pressure. And the simplest way to think about driving pressure is that rate of change, that expansion pressure that the alveoli are feeling.
So practically, when I'm utilizing a bag valve mask, how do I control driving pressure?
Yeah, and I think it would be how fast you're squeezing would be the best thing. So we know that we're giving the breath over 1 second, but if you even, I'm trying to show my hands, but if you're listening to this, if you
It's visual. Go for it.
if you pushed really hard and squeezed your hand together fast, even if you applied it over 1 second, that change in pressure that you have pushed from no pressure to that entire pressure that you're now applying into the lung, that is rate of expansion. That is driving pressure. Now, not all of what you're squeezing is going to make it to the lungs. That depends on physiology. But some patients, if their airways are nice and open, they're going to feel the majority of it. And we really want to keep those pressures a lot lower than you think.
Yeah.
Like we always think of the end pressure being, 25 centimeters of water so that we don't have gastric distension. Well, our driving pressure limits are 15. So depending on the physiology of your airways, if you are squeezing too fast, you should always think a gentle squeeze to minimize that. So you're squeezing over 1 second and it is a gentle squeeze. And again, I'm showing with my hands, but just like you don't want to squeeze the sandwich. Like you don't want to cause your bread.
All the
fly.
peanut butter and jelly will squeeze right out.
Exactly. You want to be a little bit softer in your approach with that.
Yeah. Okay. And then you also mentioned another common mistake. So driving pressure, too much volume. What were some of the other common mistakes people make?
The one other main one that I kind of hinted at the beginning is not giving enough exhalation time. And I think one of the things that we have to be aware of as clinicians, and like in mechanical ventilation, this is an entire like principle of thought, is that when we are applying positive pressure for inspiration, we can bully the air in. That's the best way to describe it. We can make it happen a little.
I've seen some people bully the air.
Yeah, and we don't want to be a bully. We always want to think gentle, but we really could if we wanted to increase the speed that inspiration happens because we are using positive pressure. And on a ventilator with a closed system, we can be a little bit more aggressive with that and still be safe, depending on physiology. But when it comes to a BVM, even though we are applying that pressure and inspiration, expiration is still going to be passive, meaning that once the lungs are full and we let go of the squeeze, the lungs are going to passively deflate. There is nothing that is going to accelerate that exhalation if you have a patient who's passive. And that means that the speed at which your lungs deflate is going to depend on two and only two things: the airways that the flow is moving through to come out of the lungs. And if they're tight, it's going to slow that flow down. Or it depends on the elastic recoil of the lungs themselves. And think of it like a door shutting. The heavier the door, the faster it shuts, versus a flimsy door that might kind of be a little bit slower.
A common physiology where we think about really tight airways, slowing that exhalation time would be like asthma, severe asthma. What would be a good physiology for people to think about for the compliance issue?
Well, you can always think about ARDS, but if you don't know, you can even just think about lungs that have less compliance in general. So it could be something as simple as like CHF, essentially, with all of the increased flooding of the alveolar capillary membrane, you're going to have lower compliant lungs. You're going to have atelectasis. And when you have less stretch of your lungs, that is going to overall decrease compliance, meaning it's going to cause, after your lungs are expanded, them to deflate a lot quicker. So you can think of like an elastic band. It's a good way to think about it. Like if you have a smaller elastic band and you open it, it's going to recoil very fast. It's the same idea of this idea of compliance. If you lose lung units, you're going to lose that stretch of the elastic band and it's going to recoil quicker.
Yeah.
Anything that's going to either cause collapse or atelectasis, you can think of obesity as another one. You can think of other...
Drowning?
Yeah, absolutely. And drowning's a fun one because it can actually present as both. It can actually be a resistance problem, so airways issue and decreasing the flow in and out, especially like if you, depending on the the type of drownings. You can actually have inflammation of the airways, and it's an irritation to the airways, causing them to be a little bit more constricted. But also, it can have issues with your compliance because of the washer surfactant, which is going to
Yeah.
decrease compliance.
Something you talked about, and you only mentioned it very briefly, was laminar flow.
Yes.
Can you give me just a down and dirty understanding of laminar flow?
So you can have two different flow types when it comes to how flow is moving through tubes. And essentially, like if you have flow moving through a small orifice and then all of a sudden you open up into a bigger area, you can end up having eddies or flows or more
Yeah.
flows that occur. And that's exactly what can happen with a BVM, actually, because you're going out through the attachment port and then you're going into a mask that is a larger area and then into the oropharynx that also is a wide area. And you can end up decreasing the ability of that airflow to move.
Mm.
So the
I
reason,
worked on a river for a long time, and it's very these concepts of flows are reminiscent. If a river is narrowing and widening and narrowing and widening, you end up with areas of turbulence
yes,
and stalled water. And yeah, it sounds very similar.
exactly, exactly. And we trying to keep some type of path for the air to go that is not too narrow. We want it nice and wide, but still not having all of these changes and openings that we would have. If you think about how your airway is physiologically designed when you breathe spontaneously, your mouth is the largest place. And if you're breathing through your nose, it goes down into an area that kind of has a path for that air to go. But when we're bag mask ventilating, we are only going through mostly the mouth because we're opening the mouth, which is a lot bigger or larger of a cavity than your nasal passage. And it's not necessarily following the same trajectory down the back of your throat to kind of have a path that's clear and concise. So how can we fix that and try to encourage laminar flow? Well, we can do it with any type of airway adjunct that we have, which is kind of the thought process behind whether you have an OPA or an NPA. You're going to decrease, well, yes, the tongue, pushing it out of the way. But at the end of the day,
Yeah.
giving a path for that air to go that is open, that decreases the ability of the air to like just kind of swirl in
Yeah.
the pharynx.
I think pre-hospital providers, maybe that will resonate with them. And I think sometimes that's overlooked because we shortchange it as all the OPA is doing is keeping the tongue removed. And so, if you're bagging someone with a mask and no OPA, but you're thinking, oh, well, I'm getting good chest rise, you might be still creating these really turbulent laminar flows. Is that accurate?
Yeah, I actually just thought of an analogy that might help resonate is if you had two paths that were both downhill for water to run, but one had a bunch of rocks and undulations to it, and the other one was a groove that you kind of put in the sand. Where's the water mostly going to go?
Right.
It's always going to go path of least resistance. And at its core, at its foundations, ventilation, the movement of air is always path of least resistance. And that's going to be where that air wants to go.
Yeah. Would talk to me a little bit about endotracheal tube size as it relates to this stuff. Because, sometimes we're taught in the pre-hospital world, fall back very heavily on the 7.5 tube. It'll fit most patients. Maybe sometimes you go down to a 7 for on a female. Sometimes you go up to an 8.0 on a male. But I think we don't get into the nuance of the discussion of tube diameter.
Mhm.
Can you talk a little bit about that as it relates to this topic of flow?
Yeah. And I think when it comes to endotracheal tubes, they already are narrowed. Like we are already taking an airway and narrowing. And then we're running into less of the laminar flow, turbulent flow. But now we're running into this issue of resistance being to a factor of 4, more of an implication when it comes to the flow of air than anything else.
So just because the endotracheal tube is not the same diameter as the trachea, we're already causing, yes.
And because of that fact, like when it comes to oral airways and airway adjuncts, we are dealing with the trachea having a concrete diameter, right?
Mhm.
And what we're trying to do is in areas that don't have a concrete diameter, the oropharynx that is this massive cavern, essentially,
Yeah.
we're trying to minimize that. And we're trying to encourage that airflow to go where we want. But when we're putting an endotracheal tube down, we are now taking physiology and an airway that should be a certain diameter, and we are always shrinking it because of the nature that we're putting a tube within a tube. And there's no other way to get around it. So of course, if I'm talking physics and physiology of ventilation, I want the biggest tube possible. But of course, we have to think about damage to the vocal cords and all those things and anatomically what will fit. But I will tell you, if you're dealing with a pathology with resistance like asthma or COPD, I will always advocate, if you can, go a little bit bigger.
That makes sense. And then, so laminar flow on inhalation makes sense, but talk also about the tube size with the important concept of exhalation that you've already spoken to.
Yeah, and talking about that exhalation being based on those two factors of compliance and resistance. So by nature, you and I exhaling passively, as soon as you put an endotracheal tube in, you are going to delay exhalation. So you might think to yourself, oh, I'm going to breathe the same way at the same rate with a BVM that I would breathe physiologically. Well, guess what, bucko? Even with an 8 endotracheal tube, that patient has more resistance to that airway. And that's going to mean their exhalation is going to be slower intrinsically because they have a tube within a tube.
Yeah.
So even with the biggest tube you can possibly put in, exhalation is going to be a fraction slower than you. So even if you're not gas trapping, your patient could be. And that's not even adding physiology. And then the smaller and smaller the tube gets, that's going to amplify that issue of slowing exhalation down. Again, to a factor of 4, to a power of 4, not just multiplied by 4. It is to a power of 4.
Wow. Yeah. That takes me back to like high school math a little bit. So yeah.
Yes.
Yeah, mechanical ventilation for a long time was only thought of as a critical care skill, but as the technology and the devices improves, it is becoming more common in 911 settings, even in agencies that have shorter transport times. So, what are some pearls you might have when you are transitioning someone from mask ventilation to mechanical ventilation? Because often we're doing it in the field. We're the first person to make that transition
Yeah.
in the field.
Mechanical ventilation, non-invasive ventilation, all of these tools, they're going to explode within EMS very, very soon. It's coming like a freight train. And I truly think that sound basis in physiology to explain these concepts, it doesn't have to be complicated. It can be as simple as straws and balloons, which is what I use in my talk.
Yeah.
And it doesn't have to be scary. But the amount of like little pearls and wisdom that when you start to approach your respiratory patient from a standpoint of physiology and understanding pressure gradients, movement of airflow, and all these things, the payoff with how you are going to be bagging your patient is, I can't even overstress that. And it literally takes just a little bit of time to really understand those concepts. But then what that information could then do for the patient when they get to a mechanical ventilator. So even if you don't have a vent right now and you're bagging, if you were able to go to hand off to someone that has a mechanical ventilator and say to them, hey, my patient had this diagnosis. I was initially bagging at a rate of 12 breaths per minute. And I noticed that my patient was showing evidence of gas trapping or auto peeping. I wasn't getting a plateau in my end tidal, all these things. And then you said, I slowed down my bagging to a rate of 10. I had sufficient exhalation. It was a lot easier to bag. We're getting the volumes in, no problem. The amount of information that ventilator clinician, whoever they are, can then take and understand that they have a high resistance situation and what that's going to do to impact their pressures. It translates immediately and it sets that patient up to potentially be fast tracked even by a few breaths from the information that the clinician would get on the other end. And not to mention, you've been doing a heck of a job bagging using physiology as your like pocket ace that like you may not have thought about before.
Yeah, to hit on that for a second. I mean, something that resonated with me that you talked about is we're often taught in our initial paramedic education some rules for bagging, ventilating the patient, but that's based on a normal patient.
Yes.
And so, what are we've kind of talked about a little bit, but what are some physiologies that right away? I mean, asthma, yes. Are there any others that stick out where like we automatically need to be altering those norms in our head?
Honestly, so many of them. Like it's
Yeah.
hard to name them all. Like you could go down like
A
COPD.
trauma pathway or yeah.
Well, and trauma is an interesting boat that you could even dive into because then you have to think about like you have your goals of hyperventilation, but you also have to think about am I hyperventilating safely? Because if you're gas trapping, then you're increasing intrathoracic pressure, which is going to decrease the drainage of your cerebral spinal fluid that's going to negatively impact
Right.
your ICP. So you might be thinking that you're helping by driving your CO2s down to low normal. We're not going crazy, but by doing that, you could potentially auto-PEEP your patient and harm your patient. This literally is like I don't know, spider webs. It can go to so many different places, but like the big buckets that I always like to bring up is like you have your asthma and COPD. You can think about cystic fibrosis. You can think about bronchiectasis, things that are going to affect your airways, and things with extra secretions that are sitting in that airway is going to increase resistance. And if you're not able to suction those secretions because you don't have an advanced airway and you're bag masking your patient, you're going to have more resistance. So anything that's going to impact either the amount of secretions in the airway or just the constriction of those airways, you have to be cognizant of as increasing resistance. And then on the other hand, with decreasing compliance, we've already talked a little bit about CHF, ARDS. So any type of septic picture, the patient's starting to go badly, but you can think about pulmonary fibrosis or interstitial lung disease. You can think about pneumonia that can sometimes show us elements of both, depending on if there's secretions in the airway or consolidation.
Yeah.
So I feel like I could talk all day, every day, but even healthy lungs, like trauma, could potentially have implications for other things. And like thinking about a bleeding patient who's hypovolemic, if you auto-PEEP that patient, if you gas trap that patient and don't allow sufficient exhalation, we all know this, but we're increasing intrathoracic pressure. That's going to cause our blood pressure to tank again. And chicken or the egg, are they bleeding more or did you cause it?
Right. Or even just thinking through many of the patients were, even if we're labeling them as normal, some of them are in cardiac arrest. And what are we doing? We're doing chest compressions, which is traumatizing the underlying structures in the lungs. So
Absolutely.
yeah, being ready to react to the feedback that the last question I have for you is, do you have any tips or pearls for honing your ability to perceive feedback in the BVM? I think some of what we were talking about is, I know when I squeeze too hard, I know when I squeeze too big, but is there any other practical tip that someone could clue in on when they are using a bag valve mask that maybe they're not thinking about?
I think any type of feedback device that you can use is always a little bit of an advantage. So if you have something that reads your volumes or if you have something that reads pressure, that's helpful. But I think a little rule of thumb to kind of eliminate that shearing forces that we've talked about is have a goal set in your mind that when you are squeezing that bag and you're going to end your squeeze at the end of 1,000. And then when you come off, you need to make sure that in between is at least 3 seconds before you go ahead and give another breath, but then recognizing that physiology is going to have an impact. When it comes to actually feeling hard to bag, it's hard to separate whether it's a resistance problem or a compliance problem with just what you feel. But that's where you can think about the most obvious physiology you think you're dealing with, and then you can start to go that route. You can make a guess, an educated guess. I have a patient who presented classic CHF. I think that I have a low compliance situation. Okay, I'm going to experiment and say, I'm going to try to apply PEEP for this patient to see if it gets easier to bag. And if it does, you just answered your question. You're going the right direction. Now, if it gets harder, then you have to revisit and say, did I change what I was doing, or did that setting decrease effectiveness? And if the answer is that you didn't change what you were doing, then go back to what you were doing before and then try a better guess.
Yeah. Awesome. Melody Bishop, thank you so much. Great talk, and great to talk to you about mechanical ventilation and BVM. I could do it all day.
I have good too. It's not scary. It's literally, I truly think that no matter what your scope of practice is, just dabbling a little bit into it and like trying to wrap your head around it. And like shameless plug, I have a free book you can find on Google it. Just Google my name and basics of mechanical ventilation. It's meant to take someone from I know nothing to a working understanding of what's happening. And it's explained as simply as possible to make it approachable for everybody.
Well, awesome. Thank you so much.
Thank you.
That was Melody Bishop after her talk at FASTCAN this year, breaking down the physiological complexity hiding behind what we often think of as basic bag mask ventilation. Let's recap the principles in this conversation, the principles that you can take with you on your next call. First, insufficient exhalation time is likely the biggest mistake we're making. That bag reinflating doesn't mean that the lungs have fully deflated, especially in patients like asthma patients, COPD, or even trauma when you're dealing with compromised lung mechanics. The more you breath stack, the more counterproductive physiology you create. Give your patients at least 3 seconds between breaths, not just until that bag refills. Second, driving pressure, or the rate of change in pressure as you squeeze, matters more than the volume itself. Think gentle, controlled squeeze over that full 1 second, not a quick, hard squeeze. You're not trying to bully the air in. Third, airway adjuncts aren't just about moving the tongue. An OPA or NPA creates a pathway for laminar flow, reducing turbulence and making your ventilations more effective. But the biggest takeaway you need to bring to your next shift? Stop thinking of bag mask ventilation as something you can hand off to the least experienced person on scene. This is a skill that requires understanding of the underlying physiology, and that understanding directly translates to better patient care. In fact, when you hand off to the receiving team, don't just say, "I was bagging at 12 per minute." Tell them what you observed. Did you notice any air trapping? Did you have to slow your rate down to allow for more exhalation? Was it getting easier or harder to bag? That information may help them dial in their ventilator settings faster. Remember, Melody has written a free book called Basics of Mechanical Ventilation that takes you from knowing nothing to a working understanding of these concepts. You can find the link in our show notes. The world of mechanical ventilation, as she says, is coming to EMS like a freight train. But armed with this physiological understanding, it doesn't have to be scary. In fact, it can be empowering. Thanks for listening to Loud and Clear. Like and subscribe. If you enjoyed this, share it with others and leave us a review. Follow us on Instagram at EMS Loud and Clear. And until next time, keep cutting through the noise and focusing on what matters most for your patients.